What I wanted to do today is to give you a journey of sorts, to give you a sense of where were we going with all of this, what were we thinking, where are we now, and are there some practical tips that I can give you as you're thinking about how can you be successful in the future around value-based payment. So in order to do that, I thought it would be helpful to sort of give you these 5 perspectives. And it's really a journey about someone I know who started out in a think tank, then went to government to try and implement some of those ideas that they had at the think tank. Then they said, gosh, you know, I bet it's really hard to implement some of these ideas. I think I'm going to go work for a provider to see what it's like to actually try and do these things. And then they thought, it's really kind of hard on the provider side doing these kinds of things. I'm going to go advocate on behalf of those providers. So I don't know anybody like that, but I'm going to give you those perspectives anyway. And in order to help myself keep track and to help all of you keep track of who I am, I got a few props. So I'm going to start out with the thinker. And no, I do not wear glasses yet. So thinker, you're thinking about the healthcare system. What are we going to do to change it? And you're thinking about it in a global sense of how does it interact with other programs? Where is the spend? What does it mean if we're paying for healthcare but we're not paying for education? What does it mean if we're paying for healthcare and we're not paying for social services? And the data that I was looking at the time, not that I'm talking about myself, but we're talking about 2009, 2010, where is a lot of the spend going to? Well, there's a lot going to healthcare, and you can see from this chart in a global sense, if we're paying more for healthcare, we're paying less for education, we're a less competitive country, is there something we can do in healthcare that will make it more value-based, where you're getting better outcomes at lower costs? So that's the initial look as a thinker. And then once you get down into the programs, you start to say, well, where are the funds? And where can we target our efforts? So this chart is just showing you national spending by sources of funds. Hopefully you can see some of the differences there. This is when the glasses come in handy. Private insurance, Medicare, Medicaid, out-of-pocket, other types of healthcare services. And the majority of a lot of the payment in this country is going through government sources. So then you say, where could we seek savings? And you look by type of services. And this chart is showing you national spending by type of service or product. And you're seeing that a lot of it is going to acute care and all those kinds of things. Good to know. So then you say, well, what about New York State? How do we compare? What can we do here? If you think back to 2010, I don't know how many people were in this field at that time or paying attention to what was happening in state government, but Medicaid was, I would say, one of the things in the state budget that took the most time and attention. Why is that? Well, there was double-digit growth, there was high spend. If you compared Medicaid, it was one of the, in New York versus the rest of the country, is one of the most costly in the nation. We also, as Greg pointed out with a lot of his good slides, we had the most avoidable emergency department use. We had less than average health outcomes. We were tended to rank a lot of times in the 3rd or 4th quartile comparatively. And not that the process for negotiating the budget is any more functional now than it was then, but it was particularly dysfunctional at that time. It always held up the budget, a lot of infighting going on because it was so contentious in healthcare. And we weren't proving that we were getting better outcomes for all we were spending. I'm all for spending as much money as possible if you're going to get good outcomes, but if you're spending a ton of money and you're not getting good outcomes, maybe there's something that you could fix. And comparatively, New York, expensive. This shows you a breakout by population. I don't necessarily think it's a bad thing that we're spending a lot of money on people. I think there's a lot of great services that you can get in New York that you can't get elsewhere. But it's important to remember that you're looking at different populations. And really, it's not just about the money, it's about the people that are supported by these programs. Medicaid is really more than health insurance. If you think about who's being served by Medicaid and what that means, really the vast majority of the people are a lot of young kids, families that really need this kind of insurance that might otherwise go personally bankrupt if they didn't have a program like this. But there's also the vulnerable population. That's why I have that circle down at the bottom. These are people in nursing homes. These are people with disabilities. That's where a lot of the dollars go. So a critically important program really deserves the time and attention to figure out how to make it the best program possible. So here I am, I'm still at the think tank, and we're looking at what are the drivers of costs in healthcare. Some of them are the healthcare system. Some of them are societal costs. I would say some of the things that we were noticing, there was a lot of variation in care, so there weren't necessarily good and consistent standards about the care that was being delivered. There were also a lot of duplicative tests, as you all know at the time. New technologies, prescription drugs, those are good things. They're helping advance care, and they're also helping improve outcomes, but they're expensive. Administrative costs, a lot of overhead, lack of coordination in care. Greg had some great statistics and information about the lack of coordination and how that impacted outcomes. And the workforce overall. Very important part of the healthcare system is the workforce, but if you want to have a good workforce, you got to make sure you're investing in it. And then there's also the societal things that are happening at the same time. So the population is aging, there's rising chronic disease, there's obesity, behavioral health. All those issues that you might notice tend to match up with the projects that you're working on in the district program. So what do we say in 2010? Remember that thing called the Affordable Care Act? Remember all the debate that was happening at the time? They said we want to change what's going on in healthcare. So it wasn't just us in New York, it was also happening at the national level. And this whole idea around the triple aim, which to me is still the thing that guides the work that I do every day. I believe in it passionately. I do think that we can have better care at lower costs, which is really the definition of value. And that really set a framework. I think it's the simplicity of this that has helped drive a lot of the different reforms that you have all seen happening in healthcare. So, long about this time, I decide, why don't I get into government? Maybe I can influence some of this. So, get rid of the thinking glasses, get to government. Can y'all read that? All right, so here I am in government, right? All my rules. Oh, those bureaucrats, they're always making more rules, making our lives tough. And what are we going to do? Well, as bureaucrats, what do you think we do? We come up with a whole bunch of clever acronyms. Here are some of those, otherwise known as programs and funding streams, just a few. And I hope that these are familiar to most people in the audience. Are these familiar? Yes? You've seen? Yes, okay, good. So you might even be able to tell me exactly what these things are. The first one on the list, let me just touch on a couple. State Health Improvement Plan. This was a blueprint, basically, for the state of New York that we submitted to the federal government that said, this is how we want to change our healthcare system. We want to achieve the triple aim. This is how we're going to do it. And one of the things that was in that plan was about moving towards value-based payment, because we felt the only way to make it sustainable was to move towards value-based payment. Federal government came up with their own list of programs, some of them very complicated. The bundled payment initiative, the accountable care organizations of various forms, the comprehensive joint replacement, you name it, it was there, MIPS, MACRA, I don't even have some of them on here. We actually tried not to make it so complex. We just went for this little program called DSRIP that you might be familiar with, that's why you're here today. And we tried to see what was happening at the federal level to try to be in line with what was happening. And you all know that Medicare has very similar programs. At that time, their goals around moving towards value-based payment at Medicare were perfectly aligned with New York. In fact, we thought they were kind of copying us, but we thought this is what we need. We can't just have one payment source moving this direction, we need to have all of them. So the SHIP said we want to move private insurance in this direction. Medicare was saying we want to move Medicare, and we were saying as a state we want to move Medicaid in that way. So what do we do? How do we get there? And what we needed to do was change the rules. Maybe we should throw these out. But we also needed the resources for all of you to try and change what you were doing every day. And the collaborative solution at the time was the Medicaid redesign team. You all know this process of let's get everybody together under one tent to figure out how we bring costs down. A lot of recommendations, 200 plus recommendations. The great people at the Department of Health, like Greg Allen and Liz Meese I saw in the back, all working on how do we implement these different reforms so we can create some savings in the Medicaid program. And we were able to do that, able to save a bunch of money. So we went back to the federal government and we asked for an 1115 waiver, which is a research and demonstration waiver, and said, we're saving you well over $10 billion. Let us keep some of that money, reinvest it, and help move in the same direction. So we aligned that vision with the State Health Improvement Plan. We got additional resources through the SHIP grant, which was $100 million to help us on the insurance side. And the state itself, and I remember this well because these are the late nights that Greg is talking about, fighting with the environmental folks, fighting with the transportation folks, and saying we need money for capital because we didn't get it in the waiver. We need money for information technology infrastructure in the healthcare system to help move this transformation forward. So we were pretty lucky those first couple of years. We fought hard in the wee hours of the morning with all of our colleagues and got some good investments to help support what the waiver wasn't going to support. And in that point in time, I felt like we were on a pretty good path. We were launching the exchange. We were going to cover more people. The exchange itself, I just wanted to point out with this next slide, was very focused on that what's in that blue box right there of people who weren't covered by Medicaid, weren't covered by employer-based insurance, weren't covered by Medicare, but people who were typically trying to afford insurance on their own. And for that population in New York State, I think the exchange has been incredibly successful. So it felt like we were really in a good place. And so how are we going to sustain this reform going forward? This is where we said, all right, we've got to align private insurance, Medicaid, Medicare. We've got these different tools, we've got these different programs. And in New York State, we were developing our own specialized Medicaid value-based payment models that were focusing specifically on some of the populations that we thought would benefit most, where you'd be able to improve outcomes. And the early results, honestly, were quite promising. One slide ahead there, where we really started to see the per capita cost of Medicaid going down, in fact, to some of the lowest levels that it had been since the early 2000s. So feeling pretty good at that point. So I'm thinking, gosh, well, let's get to the provider side of the world and see what it's really like to try and implement these things and be a provider and figure out how to do this. So this is the closest I could come to the white coat. So some of you, I see Dr. Phil Howard here, familiar with this. You know, I get to the hospital and working with a lot of doctors, working with the providers, whole new world. And trying to figure out, first of all, how do we keep our doors open? We're not really necessarily concerned with VBP, BPCI, PCMH, CPC+. We're concerned about the budget, everything else. And we're highly fee-for-service dependent. Medicaid is not necessarily the biggest payer in our marketplace. Now, in some parts of the state, Medicaid, Medicare are the biggest payers. And in fact, for them, the motivation to change to value-based payments was much greater because that is their biggest source of funding. But for organizations and hospitals and other PPSs where you're much more dependent on private insurance, people who have that, you don't necessarily want to change your whole business model just because of that. And so you're looking at these major proposed changes in financing. You're thinking, my gosh, our environment is so highly regulated. How are we going to move to that form of financing if it's only one small part of our income? And by the way, the small part of our income that is, it's really not adequate. We take a loss on a lot of the services that are being paid for by these public programs. And in order to fill in those gaps, there's all these little supplemental funds for the CAS, the SCAs, the PIPs, the VIPs, the VBPQ, whatever it is. That's how we're trying to fill in the gaps. Very confusing, not necessarily looking at our entire bottom line. And we're also saying we've invested a lot in brick and mortar. That's what consumers have wanted. They wanted an urgent care in their community. They wanted outpatient services. They wanted all these things. And so we're very stuck in brick and mortar. And so doing new things in technology that might make those brick and mortar buildings close doesn't seem like the best idea because we just spent all of that capital money trying to build those places. So we're feeling a little bit not so flexible, not nimble. We're not feeling transparent about where and how the future is going. So a little bit more stressful being on the provider side. But not only that, adding to the stress is the fact that everybody's telling to keep our costs down, but everybody also wants us to be the best. They want to have the best doctors, the best care. They don't want to have to go to Boston or New York. They want the people who are being trained to be highly trained, very qualified. They want all of these different things in the healthcare system. And so we're trying to deliver on that at the same time that we're being told to bring down our costs. So we start to think, which way are we going to go? What are we going to do? Are we going to stay in the fee-for-service world, or are we going to try to move towards value-based payment? Mind you, that's a pretty difficult thing to do when your income is coming from different payment sources. So we say, well, we better start to understand this world of risk and value-based payment. And many of you have probably seen this chart before. It shows the spectrum of risk that you can take from things that are really just pay for performance to things that are partial risk to things that are full risk. So we're looking at that list of bundled episodes, saying which one of these should we do? And I can tell you that it's difficult to take a huge risk if you don't know you're going to get the return. So we say the safe things are, why don't we start with our own population, the people here. We're self-insured. We can learn about how to do better care for that population. And maybe that'll teach us a little bit more about how to deliver better care to everybody that we're serving. And maybe we should look at some of these bundles. We do some of these services. We'll try and figure that out. And we also say, well, what kind of risk are we going to take? Do we want to take the actual risk on ourselves? We're being encouraged. We're seeing some other providers around the country who are saying, we are going to be an insurer. Does that sound familiar? Some of these organizations like Northwell, Care Connect, they're moving in that direction where they're saying, we don't want to have a whole different set of provider insurers. We want to be the insurer ourselves. Or should we play it a little bit more safe and maybe just be held accountable for our performance? Are we doing better? Is the patient having better outcomes? So we're debating that, and as you're debating that, you've got to figure out, do you want to be an actual healthcare company? What are the different things in the marketplace, like the employers, the patients, what do they want if we're going to do that? It takes a lot of resources and a lot of analysis to decide whether you're going to do that or not. Mind you, DSRIP at this time is starting up. We're trying to figure out the governance of that. We're trying to get things going. We're thinking maybe we could learn something from this. That would be good as to how to move into this world. And we're also assessing all of these alternative payment models and looking at them. Do we want to be in level 0, level 1, level 2? What does this mean for us? So we don't necessarily make a decision, but we know we've got to move in this direction. And in order to move in that direction, you have to build all these different competencies. And this is what everybody in this room is doing. Hopefully you're doing these things. Hopefully these look familiar to you. You have to start to do data analytics. You have to start to look at quality improvement, because if you're going to get paid for value, you've got to show an actual improvement in quality. You have to also make sure that your workforce is trained. And you have to look at pathways of care, care management, all of these competencies that maybe were not necessarily things that you had before. Maybe you had some of them, but definitely not all of them. And if you don't have them, what do? How can you do value-based payment if you don't have those? In that case, you have to say, well, should we build it on our own? Is this something that's worth investing in? Well, we don't know whether value-based payment is the way of the future or not. Should we build it if we think that the world is still going to be fee-for-service? Should we buy it? Is there a consultant out there that might have the right services? Or should we collaborate? Is there somebody else that we know who's doing it that we should work with in the future? So this is what providers are going through back in 2012, 2013, 2014. And for those who want to take on risk, well, they know they've got to grow because they have to be able to manage a bigger population. So you start to see these systems, large systems, forming all over the state. And these are just general ideas of where some of those systems are. The big one coming across the border is University of Vermont. You see all the big ones coming up from the city into the Hudson Valley. Everybody's starting to compete for market share and volume because they recognize that if you're going to manage a population and you're going to take on risk, you have to have enough of a population where you can manage that risk so that one case doesn't blow your whole budget. And providers start building an infrastructure to help support that. All right, make sure we got that. Clinically integrated network, for some providers, they don't even know what that means. On the other hand, some providers who have been building that for decades, they've been working on building a clinically integrated network. It's not something that you can necessarily do overnight. It takes years, if you ask me. And you have to figure out how to manage risk. Who are you going to take the risk on with? Are they willing to do it? probably one of the biggest surprises for me was the price tag on information technology and data analytics. And that was something that boards of a lot of these organizations would question. Is it worth it? I see a lot of nodding heads. Is it worth it for us to invest in this IT? Are we going to use this? Is this going to help us? And then understanding care coordination across the network, having the ability to invest in this to begin with. Some of you have the ability, you have capital, you can do this, but lots of small community-based organizations do not have the capital to buy the information technology and to buy the analytics that are necessary to do value-based payment. And then you've got to bring it to scale. And all the while, the providers are trying to improve their competencies. They're looking at how they integrate their analytic capability. They're looking at these different models, trying to help them move forward. And they're looking at the world around them, and they're reading the magazines that all the CEOs read, and they're saying, oh my gosh, look at all these other providers. They're becoming insurance companies. They're changing the way they're doing it. It's in all of the health publications about the direction of value-based payment and all of that. And they're getting pretty nervous. And in the meantime, trying to build their competencies in value-based payment. So around this time, what would it be like if you're no longer actually no longer the doc, but you're working to try and advocate for all of those people? Well, that's where I have now no costume. I'm advocating for providers and trying to navigate this world and survive in this world. And where are we in terms of value-based payment? This graph shows Medicaid, it shows Medicare, it shows who's in what levels. And we're doing some of it, which is a good thing. A lot of it's still in those lower levels. I don't know about the folks in the room who are from the state, but I'm kind of nervous as to whether we're going to get to the goals around 80–90% by 2020. And there's some other things going on nationally that you're wondering, where is all this headed? At the same time, you're looking at the private insurance market and all those people who didn't have it before, and it seems to be relatively stable at the moment. We'll see what happens with this tax reform bill and the individual mandate and all of that, but things at this point in time, relatively stable. I think we're in a much better place. And the Affordable Care Act, regardless of your political viewpoints, I think it's hard to argue that the ACA has had some successes. It's enrolled a lot of people in marketplaces. It's allowed the Medicaid expansion to cover a lot more people. The employer-based system hasn't imploded like a lot of people predicted, and premiums, despite what you hear in the news, had been growing at a pretty high rate. Yes, they're still growing, but I think they're growing at a moderate rate relative to what they could have been growing at. And what about accountable care organizations? A lot of different conclusions, I think, on whether it's working, to what degree it's working. So I tried to get some current information, and in fact, there's information coming out every day. Yesterday, some of you may have seen, there was a report by the United Hospital Fund that talked about the ACOs in New York. And out of the 30, I can't remember if it's 32 or 36, only about 10% of them were successful at creating value. Only 6 of those 10s created enough value and good outcomes that they're actually getting a bonus of some sort. So a lot of effort and investment on the part of providers with some mixed results. And this one, which was from the Health Affairs, said 56% of MSSP accountable care organizations saved relative to their benchmark. And 31% of the ACOs received the shared savings bonus, which is about the same percentages based on what I just said about New York's program. So in my view, that's better than if we didn't have ACOs and didn't have VBP. We're having better outcomes. Maybe we're not creating all of the savings that the government had hoped for, but to me it's somewhat better. And if you're looking for scholarly articles to cite in terms of what is the success of a lot of these different alternative payment models and value-based payment, these are 2 of the best references. They give a lot of details on which of the programs, including PCMH, including MSSP, what's worked, what hasn't worked. And again, the results are mixed. They're saying that in a lot of instances, you're not necessarily saving money, but you're having better outcomes. Same thing with commercial ACOs, looking at, and this is from Health Affairs, you're looking at some better outcomes, some savings, but perhaps not the same degree that everybody was hoping for. This next slide I really just put in as a reference for you for all of the different innovative models that are happening and the scope of value-based payment. And you probably can't read it up there on the screen because I certainly can't read it here on the podium. But it talks about what those different levels are, what models are working, what models are doing better. And in terms of the commercial market in New York State, most commercial value-based payment is in the most basic of all, the level 1. About 16% of providers are impacted, about 13% of enrollees impacted. So going back to that business hat, you're saying, how much investment should we put in value-based payment? You're still kind of saying we're largely in a fee-for-service world, but we still have to continue to build our competencies over time. And this slide also shows the overall Medicaid value-based payment activity in New York State, which is about the same, frankly. So moving slowly at the same pace. And so you say to yourself, well, what happened? Just a couple years ago, we were hearing all about those plans that wanted to take providers and be provider-based insurers. And do we still want to do that? Well, you're saying, all these hospital-sponsored health plans don't seem to be doing too well so far. And in fact, one of the biggest ones in New York decided to get out of the market, Care Connect. So now you're starting to say, maybe we shouldn't be the insurer. Maybe we should do something else. And you're trying to assess what has been the overall result of this so far. And you say, the transition of value is definitely happening, but it's happening much slower than we thought. Well, only 13 hospital systems out of 80 respondents said that they derived 10% or more of net patient revenue in 2015 from risk-based contracts. More than half of the surveys from this was the advisory board, reported that over 60% of their revenue still comes from fee-for-service. And what about DSRIP? Also along the same lines. Moving forward, but perhaps not as rapidly as was hoped. And so you start to wonder, are the incentives enough? Can we better align them? And you're looking across all these different programs and acronyms that I started with, and you're saying, slow movement, inconclusive results, new limits. Fee-for-service remains at the core of all this. So before I get into where do we go from here and the prognosticator part of the presentation, I think it's important to just stop and reflect. So all of this time and effort, you're saying mixed results, not really sure. Sometimes it works, sometimes it doesn't. You have to ask yourself, why do we start all this to begin with? And I would say it comes back to the patient and the outcomes. It's not necessarily all just about cost. And if we've seen an improvement in outcomes, which I believe we have, and it's not really any more costly than it was, and in a couple instances, it saved us money, to me, it's definitely worth continuing. As you know, change does not happen quickly. So that's what I wanted to say before I get into the state of affairs and what's happening in the future, which is going forward. And I do have in here, hopefully, my crystal ball, if only, right? So what's going to happen in the future? Think about it with Medicaid and Medicare. We don't know from day to day whether the Affordable Care Act is still going to be the law of the land. It was like this summer, the night of the living dead, I swear to God, because every time you thought Congress was bringing up a bill that was going to kill the ACA, you defeated it, and you thought it was dead. And then there it rose up again, 5 different times. And here we thought it was going to be done, and they were going to focus on tax reform. And what are they doing in tax reform? They're trying to kill the ACA. So, I don't know. I kind of feel like just kind of chuck this. It's useless, but but I do know one thing, and that is that there's going to be continued fiscal pressure from the federal government to bring costs down. And so the things that you are doing in VBP that are related to cost probably are still worth pursuing. MACRA, really uncertain what's going to happen with that on the Medicare side of the world. There's new federal leaders. Well, I don't really know yet what this HH secretary that's very new, don't know what his agenda is. Certainly different than Tom Price. Tom Price seemed like he really wanted to kill value-based payment. However, Seema Vera, the head of CMS, seems to be somewhat supportive, but not wanting to do it in a mandatory way, not wanting to take the book of rules and throw it at the providers, but allow it to be voluntary. So there is incentive to keep going. If you think you can be successful at value-based payment, you're going to make money, you're going to make patients better. Why wouldn't you try to keep going? And what about the New York landscape? Right now, very difficult to say. The state is facing some very tough times. In many ways, I'm glad I'm not there to have to make some of those really tough decisions because they're never fun. But $4.5 billion gap to begin with, and that's before tax reform. I have a lot of anxiety to think about what's going to happen to the state of New York should this tax reform legislation pass, and the amount that it's going to cost the state overall, what it might mean for the future of the state, a little bit of anxiety there. So, and then you look at Washington, and all I see coming from Washington in this current state is cuts in healthcare. I can't say much that's very optimistic about that, other than we live in a democracy and there's elections every few years, and so we'll see what happens. How much damage can be done in a short amount of time? I don't know. So trends in medical costs. We were doing pretty well for a while there with the ACA. I think getting more people insured, focusing on prevention was a positive thing. You started to see a decline in overall medical costs. But now the prediction for 2018 is that we're going to start to see an uptick again. And I'm not quite sure what that means for the future of the program. Meantime, outside of what's happening in Washington, there's this thing called the healthcare marketplace. And that is also changing dramatically, as you all know. There are new things happening in healthcare. This first example of one of those trends is about Anthem, which is a large national insurer. They're feeling the pinch. They got to help their stockholders. So what are they going to do? They're going to start denying all these different types of services. They're going to say, we're no longer going to pay for these things in inpatient settings. We're only going to pay for them in outpatient settings, even though our contract says that we'll pay for them in inpatient settings. So that puts more pressure on providers because they earn more money if it's in an inpatient setting than they do in an outpatient setting. And so they're actually challenging it, and I wouldn't be surprised if there's a legal challenge. Another trend in the marketplace more generally that you all know, because you're one of them, is consumerism. And there's a growing segment of healthcare consumers. A lot of this, I think, is the new generation and the technology that they have. They look at the healthcare system and they say, wow, it's really expensive if I go there. How much is this going to cost me? And they realize they can't always find the answer. And they're saying, well, how come I can find the answer in anything else that I buy, but not in healthcare? So there's been a gradual move to make things more transparent in terms of the price and the quality. They also look at things like when they're trying to get an appointment, which was your perfect example around dermatology. Why should they have to wait? Why can't they just click something on their phone and talk to the doctor on the other end? Why do they have to go to some inconvenient location when there's limited hours and then there's billing that they don't even know what the bill that they get in the mail means? So a lot of these things are ripe for change. I'm all for consumerism. I think it will help drive some of the innovation in the marketplace. But meanwhile, we are those people who have to make all those changes. And those changes require investment, time, and money. In the meantime, we're competing with other organizations. Now, originally I had Walgreens on here, but I should have known and put CVS instead, given all that happened this week. Yeah, Walgreens, but it's one and the same. They're both competing with each other. I think CVS made the better strategic move sooner, recognizing that there was a big market. And their partnership with Aetna, I think, is one of the most significant things that's going to happen in healthcare this year. And then overall, there's disruption in the market. Organizations that normally don't have anything to do with healthcare are getting into healthcare. So Apple is apparently looking for ways to branch out into healthcare, specifically primary care. And whether they compete with the CVS and Walgreens or whether they partner remains to be seen. There are some smart providers out there who are saying, maybe we should partner with CVS because they've already got all the locations that we were planning on putting some of our outpatient centers or urgent care centers. And why would Apple be doing it now? I think because they're well positioned. They've hired a whole slew of top healthcare executives to get them ready for the future. And bigger companies that also have dabbled in healthcare are also starting to look at what can we do with the technology and the innovation that we've done in other sectors and bring it to healthcare. So GE, IBM, they're looking at what's called IoT, the Internet of Things. This is really the big data concept of we're going to be able to provide you better healthcare because we know all this other data and information about you, and we're going to use it to improve your care, right? Who's going to argue with that? They just have to figure out how to get into the marketplace, and they're beginning to do that and bring their innovation there. There was a whole health affairs blog that featured the diffusion of innovation as well. How does it happen, and how is it happening in healthcare? And it definitely is. So what are you going to do as a provider to survive all this? I would say one of the first things to do, whether you're a community-based organization or a healthcare organization, is understand your costs, because price point is going to be more important for consumers in the future. So what is really going into all your costs? How are you allocating those costs? One innovative provider, and I use the example here from Utah because there was a nice New York Times article about it, actually went through and said, we've been negotiating contracts with insurers for years, but we haven't necessarily known the actual cost of this care. We've had a price that they pay, but how much time of the doctors is it taking? How much of the nurse practitioners? How much are we using this technology versus that technology? And they have actually gone through and itemized and come up with the actual cost of services so that they can begin to see, well, maybe we don't need the doctor for that. This is well within the scope of the nurse practitioner. Maybe we can use her for this part of the procedure. And maybe we don't need the Da Vinci robot, blah, 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 because it's just as effective to use this other type of machine. So they're starting to pay more attention to that. And I would say, if you're a provider, even if you're a CBO, you probably have a lower price point. You're going to start to see providers pay a lot more attention to the actual costs of care. And providers are also starting to respond to the cost pressures by doing things that, first of all, improve their revenue. So a lot of providers have done the things that are labeled hard, which is looking at your productivity, looking at your revenue cycle. Now a lot of them are moving into more business service reconfiguration of how do we deliver services more in a continuity for the patient. What do we do with our physician enterprise and the management of it? And some providers are even doing the hardest things there, which is really looking at clinical redesign. And this is where I say, PPSs, value-based payment, you've been working on the hardest part of this already. You're the ones who have been out there saying, no, let's look at what's clinically effective. And you have some of those answers. So this is one of my more encouraging parts of the presentation, that you've seen through clinical pathways, through different care management techniques, through partnership with CBOs, that there are ways to, in fact, improve care. Providers are also recognizing the importance of data analytics. You really can't do value-based payment and get paid for it if you can't prove that you've reduced costs and improved the outcomes. And so these are some of the data sources that providers are using. There can be additional ones, but I just wanted to give you an idea of them. And then they're getting technical. I mean, value-based payment is not easy. You have to understand where the opportunities are. And a lot of them, if you look in the high volume areas where there's a lot of variation, that's probably where your best opportunities are going to be. And this is my one commercial for the organization that I work for, the Healthcare Association in New York State. We do a lot of advocacy. Our members pay for that. We work very hard on that. But we also have, in order to lower our dues for our members, a for-profit side that helps providers with things that are much more complex, that really have to be charged for. And we help them identify where there are opportunities in terms of looking at their populations, in terms of looking at the conditions of that the population has, and how to improve it going forward. So getting down to the end here, and I'm very much looking forward to maybe a little bit of Q&A, and I'm so glad my voice has held with me this long. If you're thinking about, well, what are we going to do moving forward? I say that a lot of these strategies that are on this slide are ones that you're already pursuing, and they're going to benefit you whether you're in a fee-for-service world or whether you're in a value-based payment world. So the first one is volume. So you remember the slide I had up there with the big, it's a map of New York State with the big circles, and everybody's moving to gain more market share. That's a good strategy in fee-for-service because you're getting more patients, you're getting all of that volume that helps in a fee-for-service world. But it also helps in a value-based payment world because it has a larger population. You can spread the risk around. Analytics. I would say it helps in both worlds because in a value-based payment world, you have to have it in order to make sure that you get the most out of your contract. But it helps in a fee-for-service world too, because you know which service lines are more profitable, so you know that you want to grow those ones. Quality and care improvement. What's wrong with that? Doesn't matter which world you're in. So what you're doing around care improvement with the PPSs and outcomes for patients is critical. Collaboration. I think one of the biggest successes of DSRIP has been the collaboration. The fact that all of these people are here in this room today, that not only are you working together to try and find overlap and learn from each other about the different projects you're working on, but you would have no other reason to talk to each other in the past, and you were incredibly siloed. Having organizations work together on that care continuum for patients and allowing those patients more opportunities to be in a setting that they want to be in order to be cared for is an incredible advancement, whether you're in fee-for-service or value-based payment. A nimble workforce. If you're in a fee-for-service world and you're trying to bring your expense down, if you can have people who at some positions can be retrained or can spend part of their time doing one job and part doing another, that's going to be incredibly helpful. And it's also going to be helpful if you're trying to improve value. And regardless of whether you're going to be an insurer or not be an insurer, it's really important to understand how insurance works so that when you're negotiating with an insurer, you're in the best position possible. My final advice in terms of strategy is to keep going. You do not want to be the polar bear when the water melts who hasn't found the new habitat. So you got to keep going. And looking forward, I have to say that despite all of that's happened in the past decade, we are at a good point, and I hope to see this continue and not necessarily be disrupted. We do have the lowest uninsured rate in the history of the state of New York. Providers and CBOs are working together to try and figure this out to improve care for people. There's attention being paid to behavioral health, which has really been neglected for decades. And the fact that some of the district projects focus on behavioral health, there's so much more attention to it now. I hope that we will see improvements that we've never seen before. Some VBP models have worked, and scholarly journals like the New England Journal of Medicine have actually affirmed that, which is a really wonderful thing. DSRIP has had some successes. Greg highlighted some of those. I think you'll see more. I think you'll see some PPSs who won't have as much success for various reasons. I think it's important for us in the next year or two to understand why some PPSs have had success and some haven't. And finally, at least in this world, you have more control than that poor polar bear. So I appreciate the time today, and given all the work that you've done, I just want to say thank you for believing that value-based payment is actually going to make our healthcare system better, and wish you all the best. Thank you. We do have time on the agenda, and I wanted to save about, I think it's about 15 minutes that we have for Q&A. So I still have a voice too. Yes. I guess we don't have a mic for questions, but.
So you talked, so A, great talk, thank you for sharing. I love the historical component at the time at DOH. What do you think the role of community-based organizations is in an era of value-based payment? And how might CBOs prepare themselves for such a
Well, that was two questions, but I would say the role of CBOs, I think you oftentimes understand the social needs of these populations better and how to meet those needs. You also are closer to the community in some ways. So I think a couple different things. One is to, if you're part of a collaborative, to get other members of that collaborative to understand the community and the resources that are available in that community, which they may not know all those resources. For the patient's point of view, I think helping them navigate through all of those different areas where they might go for assistance, and emphasizing to the entire community, both the patients and the providers, the importance of the social determinants of health and overall health. And Greg made the point about the US compared to other states and the amount that they spend on human services versus healthcare. I think we have that upside down in the United States, where if we were focused more on those social determinants of health, are people happy? Do they have a support system around them? Do they have food and housing? That they would then be able to manage their health care. So I think your job is to continue making sure that people hear that message and working with providers to understand it and to make them know that you're a resource.
So I wanted to continue on that theme. I was really happy to hear Mr. Allen discuss the effects of underspending on social services and to see the MCOs coming around to the idea that social determinants are playing a big role in population health. And yet, for those of us who are on the front lines in neighborhoods, especially in urban settings, and I'm sure it's the same for rural settings, that social policy and funding mechanisms are still focused on the back end. They're siloed, they don't work together. This reminds me of 20 years ago in CCSI and all the commissioners talking about we're all going to work together and nothing materialized. And so the holistic lives of the people that we serve are being underserved. They're being ripped apart into categories that either fit a funding category or they don't, and the solutions are few and far between. I feel like I'm working half the time with my hands tied behind my back because of policy, not because the technology and the know-how isn't there. And so for the policymakers that are in the room, the answer to me is to integrate the system, blend funding systems. The healthcare system and value-based payment is going to fall flat on its face if it doesn't include criminal justice, child welfare, substance abuse treatment, and on and on and on. And oh, by the way, having supermarkets in food deserts, and so on. So that's a plea.
Thank God I'm not a policymaker anymore. But I do think that message is being heard. I know that the Office of Health Insurance Programs, as of recently as this week, has established a social determinants of health unit because they've recognized, and it's interesting that it's in the Office of Health Insurance Programs and not in the Department of Public Health or somewhere else, because they've recognized that health is really about that. I think the difficulty has always been the restrictiveness of Medicaid, and it looks like it has to be medically related in order for it to get reimbursed. And I think there's more and more of a recognition, both at the state level and federally, that health, the definition can and should be broadened. And if I could say something positive about the federal administration, there seems to be an openness and flexibility there, that states, if they want to apply for waivers like New York did to restructure their program, that they may be willing at this point in time to have a little more flexibility for those states to do things like look at the social determinants of health and how you might reimburse for them. I know in my time in government, we spent a lot of time trying to get the federal government to match dollars for housing, because when we asked all the commissioners, what is the most important thing that you think most important investment that would change where healthcare is headed and whether people are getting the services they need, they said, affordable, supportive housing. And New York State made that investment, couldn't convince the federal government that that was a worthwhile investment. They wouldn't match it, but the state made the investment anyway. So couldn't agree with you more. Thanks. Yes.
One of the criticisms of DSRIP or value-based purchasing, or the system, the issue, is that it's limited to Medicaid. You just comment about anything that you know related to Medicare, the federal level, and the private payers, where their thoughts are in terms of actually moving from a system that we're working on limited to Medicaid to expanding?
Well, I think from the Medicare point of view, the state was at one point very aligned with where the federal government wanted to go. And Medicare has rolled out a lot of different ways of doing value, different programs. The new federal administration has not said that they don't want to do that. They've just said we don't want to make it mandatory. So that's why I say I still believe that they're moving in that direction. It just may not be as fast as New York State. When it comes to the commercial side of the world and managed care organizations, to me that's really dependent on the community that you live in and how fast those particular insurers want to move. And it varies across the state, and a lot of times it depends on whether it's a locally based nonprofit insurer or a national for-profit insurer. So I can't necessarily answer for your marketplace, but it depends. The state is going to be implementing new requirements on managed care organizations, particularly in the Medicaid space, to incentivize them to move towards value-based payment. So there's still a general movement all in the same direction, just at perhaps slightly different timelines.
So you've said that you think that analytics are going to be very important going forward here, but your typical small independent practice has no expertise and probably doesn't have the manpower to even collect the data that's needed to drive those analytics. So what shape do you see the support coming from the state to do that sort of analysis? How do you see that playing out?
And maybe that's a question for the state, but I do think it's one of the biggest challenges. I know in one of the regional PPSs, when DISRIP was starting up, they did a survey to see what is the capability of some of these organizations to collect basic information, and it was a lot more difficult than anticipated. It was also one of the things I don't think we anticipated at the state level. So I think there's got to be some flexibility there in the contract that you might have with the main PPS as to how you get paid for what you're doing. Maybe it's not value-based. Maybe you assess what you believe is going to work and you get some kind of upfront payment as opposed to being the one who's responsible for that downside risk. And Greg, I think, yeah, I'm sure you'd have a good answer to this too. And more of a voice.
I'm just here because Courtney's voice is wearing out. So on that issue, I think the PPSs were faced with this challenge, right? Like, how do we wire together this network? We got attribution coming from all over the place. And I think the collective, because this was our money, right? We had $8 billion, we're going to put this out there, we're going to integrate, we're going to try to bring providers together. But I think that the quick thing that almost every PPS realizes is we can't pay for IT capability at every outlet, especially every small outlet. And bring that up to the state level, even after the waiver dollars are out there, even with all the patient-centered medical home incentives, the meaningful use incentives that are out there, government won't be able to shoulder the interconnectivity and the IT capabilities that are going to be required system-wide. Part of what has to happen is the carrying capacity of a reprogrammed set of dollars, and I'll take the point on social services as well, has to incentivize partnerships to share capabilities across networks to build this up, because there's just not enough capital out there to put the right kind of IT system at every small outlet. We won't be able to do it. And even when we had a significant infusion of federal money in the form of DSRIP and Medicaid, we didn't put an EHR in every small practice. So partnership is going to be really key, and leveraging cross capabilities in those partnerships is going to be important. And I think the philosophical challenge is not to lose your soul in that transaction, right? And to keep the benefit of being small, being patient focused, being consumer focused, when you actually need active partnership with larger entities, that many worry about losing that that philosophical and patient-centered community-ness. So I think one of the core challenges is how to get big and act small. And I don't have the answer for that, but I think that's a core challenge in a lot of this. Mm-hmm. And then if I could, just on the social piece and the weaving together the social rules and funding with the healthcare, in our space in healthcare, and as a payer in Medicaid, as one state in this space, we're trying to create as much pressure to integrate as possible. And where we have the leverage points, Courtney mentioned it, on behavioral health, we're doing a lot more integration than used to happen across substance use disorder services, mental health services, HIV, primary care. Those kinds of integration points are happening. The ones that you mentioned around criminal justice, et cetera, those are harder. Those conversations are happening, but I think they're gonna happen slower, just candidly. But it is the local connectivity, I think, that can start to drive some of the service integration. It is really hard, I'm just being completely frank, really hard to drive those sets of resources together at the state level. I think we continue to need pressure, just like you mentioned, to do more of that. And that is the next adventure here, is to braid together, weave together, and make these sort of things sort of inextricably interwoven. But local efforts need to provide jet fuel for state efforts. We're starting where we're at, and it probably won't go at the pace that everybody would like it to. Thanks for that.
No, thank you. Thank you. I think we have time for one more question if there's any other. Yeah.
There were statistics that show that long-term care is very costly in the Medicaid world, and I was just wondering if there has been any focus on providing the elderly with a choice, because many times there isn't a choice and they have to go to long-term care when there are agencies in the community that focus on long-term care in the home.
I'm so glad that you brought that point up, and I know the director of the State Office for Aging is here today. Raise your hand in the back there. But the importance of long-term care in the Medicaid program was on one of my slides because so many people rely on it. And the partnerships and the collaborations that have developed for the PPSs have got to include organizations that know how to serve people in the community. In fact, a lot of those providers, I think, do some of the best job because they allow people to remain independent, happy in their own home. So they've got to definitely be part of the PPSs and the CBOs that are involved. And I think there's actually a lot to be learned from what the long-term care system has done on the acute care side, because it's been more focused on what does the person want in terms of the care that they're getting. So the more that can be shared in terms of how care is delivered on that side, I think the better. I think we're out of time, but I did want to say one more thing, which is HANYS, where I work now, the Healthcare Association of New York State. We do have an expert on staff who came from the PPS, Evan Brooksby. Evan, sorry to embarrass you, can you raise your hand? Evan's been leading up a collaboration of PPSs, and I think all the ones in the room are part of that, to help with learning best practices, talk about challenges that you're all experiencing, and figuring out where do we go from here. So if you don't know Evan and you're not part of what we're doing there, I'd highly encourage you to visit the HANYS website and get to know who Evan is, because he's trying to help everybody get through all this. And once again, thank you and best of luck.